Hi, this is a overview of cardiovascular disorders. So, when we're talking about cardiovascular disorders in children, most of them are due to congenital heart disease, which affects 1% of all children. It's the leading cause of morbidity and mortality in the first year of life. A lot of these are going to be diagnosed prenatally through fetal ultrasounds, but remember that not all women have prenatal care, and so there may not be a history or an ultrasound done. For the last few years, newborn nurseries have been doing critical congenital heart defect screening on all newborns using pulse oximetry, and they will obtain a pulse oximetry reading on a right hand and on a right foot, and criteria, I think it has to be a greater than a 4% difference, will indicate a failed screening and require further evaluation. So when you're reviewing your prenatal records on any newborns you're seeing, in addition to making sure that babies pass the hearing screening, now you'll also want to assess that they pass the critical congenital heart defect screening. And in addition, you'll want to make sure that you review the mother's prenatal history, prenatal care, prenatal screenings, any complications during the pregnancy or delivery. You want to look at the newborn admission physical exam and the discharge exam. You want to look at the APGAR scores, which are a good indication of the baby's successful transition from fetal to adult circulation. Part of assessing for the cardiovascular system includes assessing growth and development, because infants who have a congenital heart defect will often have poor growth, so they'll be failing to thrive. And so congenital heart disease is one of the organic disorders that you'd want to evaluate for in a child that was failing to thrive. Box 31.1 include risk factors, either maternal or family risk factors for congenital heart disease. When we're talking about assessment of the cardiovascular system, we want to first include the history as mentioned, and physical examination will include vital signs. So don't forget to take your vital signs. They're really important inpatient, but they can often be really important outpatient, and they are not often obtained routinely. Oftentimes, when a patient is brought in by a medical assistant, they'll obtain a temperature and perhaps a pulse ox reading, usually a height and a weight, or at least a weight for a sick visit, but they usually don't obtain a pulse or a respiratory rate or blood pressure. And we shouldn't forget that we know how to do that, and we should be assessing vital signs on any patient that we're concerned about, and as part of our workup, if we're having difficulty coming to a conclusion for what the cause of the problem is, because sometimes an abnormal pulse or respiratory rate can really be an important finding, and it isn't, like I said, routinely obtained. Continuing with your physical assessment, you want to look at the general appearance. You want to notice if there's any unusual facies or signs of, like a congenital anomaly. You want to look at skin color, get a general impression, see if there's any obvious signs of respiratory distress, any signs of edema. You are going to be looking at the growth charts to make sure a child is thriving, or in some cases not overweight. When we're talking about assessing the heart, we remember our 4 assessment techniques of inspection, palpation, we usually do not percuss the heart, and then lastly, auscultation. So you want to inspect the chest. You want to look for any obvious heaves or thrills or asymmetry, any bulges in the chest. You want to look for if the point of maximum impulse is visible, which should never be visible in the newborn. Then you're going to move on to palpation, and you are going to palpate in all 5 areas of the chest, beginning with the aortic area, which is in the upper right sternal border, in the second intercostal space, across to the left upper sternal border, second intercostal space for the pulmonic area, down to Erb's point in the third intercostal space, tricuspid area, fourth intercostal space, and then the mitral area, which is in the fourth to fifth intercostal space, mid-clavicular line. And in infants, it's generally in the fourth intercostal space, and it migrates down to the fifth intercostal space during childhood. And then you want to auscultate in all these areas as well. When you're palpating, you want to palpate for any thrills or heaves. And then when you're auscultating, you want to be thinking in terms of, the phase of the cardiac cycle that you are in and the closing of the valve that you're listening over. So the aortic and pulmonic valves are closed during S2. The tricuspid and mitral valves close during S1. And so you want to be listening in those locations and thinking about what is closing at that time. You also want to be assessing peripheral pulses and palpating the liver and spleen for any signs of hepatosplenomegaly. The liver is normally palpable about 1 finger breadth or 1 centimeter below the right costal margin in infancy, but the spleen should not be palpable. When you're auscultating the heart, you want the room to be quiet. Sometimes you even have to close your eyes and really focus on what you're listening to, especially if it's a young baby whose heart rate is a lot quicker than an older child. You want to remind parents not to, speak to you or ask you questions when you're listening, because a lot of times I notice as soon as I put my stethoscope in my ears and I start listening, I hear parents start telling me important parts of the history, so I just remind them that to hold off on that until I'm done listening. So the first heart sound is S1. It's the closure of the tricuspid and mitral valves. It's heard in the beginning of systole. And the second heart sound consists of the closure of the aortic and pulmonic valves. It marks the end of systole. And in children, it's normal to hear a split second heart sound when during inspiration the pulmonic valve closes very slightly after the aortic valve. So during inspiration, you'll hear a split sound, and you do not hear it between inspirations. Other heart sounds include S3 or S4. S3 can be normal. I've heard an S3 in teenagers, especially athletic teens. Can sometimes be heard. I've never heard it in an infant myself. An S4 is always pathologic, can be heard with increased contractile force, and often with congestive heart failure. And S4 comes before S1. And so the little terms of Kentucky and Tennessee are used to sort of describe the extra heart sounds. S3 follows S2, and so Kentucky is S1, S2, S3. But S4 comes before S1, so Tennessee is S4, S1, S2. Murmurs are a common finding in children. Up to 80% of children will have an innocent or a functional murmur. Murmurs can be a sign of cardiac disease, but not necessarily. There are certain outside of the heart conditions that will either cause a murmur or intensify a murmur. And those include anemia, where there is a lower hemoglobin level, which leads to decreased oxygen carrying capacity and increased heart rate to compensate for that. In addition, the blood is thinner and moves more freely through the heart and vessels, and that increased rate with the thinner blood can cause a noise. That just the process of the blood going through can cause a sound that will be a murmur. Fever, which increases cardiac output, can also cause a flow murmur, and so can't exercise. So if you do hear a murmur in any of those conditions are present, you'd want to reevaluate unless the murmur had characteristics of being pathologic at that point. Remember also that the not hearing murmur does not preclude cardiac disease, because there can be some defects where the defect may be so large that actually the blood flows through the defect without making a sound. So don't necessarily presume that if there's no murmur, there's no heart disease. And table 31.4 talks about how to describe a murmur, and I think that's a really important table for you to look at. You should be describing your murmurs in as much detail as possible for a number of reasons. Evaluating a heart murmur by more than just how loud it is very important in diagnosing the cause of the murmur. So in addition to the grade or intensity of the loudness of the murmur, which is from grade 1 through 6, you also want to note if the murmur changes with position. You want to know in what phase of the cardiac cycle the murmur is heard, where exactly on the chest the murmur is heard the loudest, and then where, if any place, it radiates to. You want to describe the quality of the murmur. Is it a musical or a harsh blowing murmur? How long the murmur lasts. Is it all of systole, or is it early in systole, early in diastole, late in systole, late in diastole? And do the best you can with that. And then the pitch. Is it a low pitch, a medium pitch, or a high-pitched murmur? All of those characteristics of a heart murmur are really useful to you in terms of helping you figure out whether the murmur is physiologic or pathologic. And even if those don't help you find that out, if you document that in your note, it's very helpful for another clinician who listens to the heart murmur, or the referring cardiologist. If you are referring the child, then the information that you can provide is very useful. It's also useful if the murmur changes, to know what it was like at the time you heard it, so that if someone hears it and it sounds different, that can be an important thing to note. When caring for children with cardiovascular disorders, it's important for us to monitor their growth and development. Children with congenital heart disease will often have poor growth and require additional nutritional calories, supplements for optimal growth. Ensure that they're having optimal psychosocial development, because if a child has a heart defect or heart disease, they may require lots of hospitalizations. And we know every time a child is hospitalized, they regress developmentally. Remember that children with congenital heart disease are complex. They will require a medical home. They'll require management of all their specialty appointments, any referrals that need to be made to early intervention, or physical therapy or occupational therapy. They should be considered for priority when there's any flu vaccine shortage. They should be considered for Synagis vaccines, which aren't really vaccines, but are passive immunity given to children to prevent RSV infection during the season. that we need to ensure that any child who's had surgery for a cardiac defect or is pending for surgery is monitored closely for signs of infective endocarditis. And depending on what the condition is, that they achieve optimal fitness. If we're talking about children with dyslipidemia, hypertension, diet and exercise are critically important. And so there are some heart conditions that require extra calories, and there are some conditions that require less calories. We generally refer to a pediatric cardiologist if there is any abnormal cardiac findings on exam, including hypoxia that isn't pulmonary related, a child that has evidence of congestive heart failure, any murmur that is pathologic, and the criteria for that is listed in your textbook, and it includes being any murmur that occurs in diastole is pathologic, any murmur that is grade 3 or above, murmur that's associated with radiation, that is associated with a click or a snap, a fixed split S2 that does not change with position. Those are all potential signs of pathologic murmur. So those should be referred. If the murmur is not clearly pathologic, but is concerning to the clinician in any way, then as long as the child is not demonstrating signs of poor growth or signs of exertion with feeding, then the referral can be non-emergent. When we're talking about older children with dizziness, syncope, chest pain, arrhythmias, those children would be referred to cardiology. So again, in pediatrics, most cardiac problems are managed by a specialist. Very little is managed primarily in primary care. We may follow the child with guidance from a referring clinician, but we will not manage cardiovascular disease alone in the primary care setting. Genetic testing may be indicated if there are signs of a genetic anomaly, and we always have to keep in mind support for the family. Whenever a child has a chronic illness or disease, it is going to affect the whole family. Congenital heart defects are caused by an alteration in the development of the embryonic heart. The development occurs primarily between the 2nd to 8th week of gestation, and many times women don't even know they're pregnant at that point. There are some medications that can be teratogenic to the heart. In addition, alcohol and smoking can also affect the fetal heart development. There are several specific congenital heart defects that I'm not going to go over in detail today because they were reviewed with you in PC1. You should review those in your textbook. I'll talk about some overall concerns that we should be aware of, and if you have any questions about any of them, you can let me know. But basically, there are two overall types of congenital heart disease: the defects that do not cause cyanosis and the defects that do lead to cyanosis. Fortunately, the acyanotic heart defects are more common, and those include the ASD, the VSD, the PDA, the coarct, some cases of pulmonary stenosis, although pulmonary stenosis can be a cyanotic condition. And basically, conditions like these lead to increased pulmonary blood flow or obstruction of ventricular outflow. So conditions that cause increased pulmonary blood flow are the ASD, the VSD, and the PDA. Remember that the ductus arteriosus is a normal patency in fetal circulation, and it actually is there to allow blood to bypass the lungs, because we remember in fetal circulation, oxygenation of the fetus occurs by the mother through the placenta. So the lungs are not necessary to oxygenate the blood in a fetus. So the heart doesn't send a lot of blood to the lungs. It only sends a small amount of blood to the lungs just to perfuse the lungs for development. There are two defects in the circulation which are normal in fetal life, and one of them is the ductus arteriosus, and the other one is the foramen ovale. And here is a picture of the fetal circulation, and you'll note the foramen ovale is between the two atria. And in fetal life, the right side of the heart has increased pressure to the left. So any defect causes right to left shunting. And the ductus arteriosus is between the pulmonary artery and the aorta. So the shunting occurs from the pulmonary artery to the aorta, bypassing the lungs. Again, a right to left shunt. After fetal life, when the cord is clamped and the newborn takes that initial big breath, that big breath reduces pulmonary vascular resistance. The cord clamping increases systemic vascular resistance. So all of a sudden, pressures are now greater on the left side of the heart compared to the right side of the heart. So in fetal circulation, pressures are increased on the right side of the heart. In postnatal circulation or adult circulation, pressures are increased on the left side of the heart. So any defect is going to cause left to right shunting. And that is going to increase pulmonary blood flow, because the right side of the heart perfuses the lungs, the left side of the heart perfuses the systemic circulation. So if blood flows from left to right, you're increasing pulmonary blood flow. And that's usually why you do not see cyanosis. In mixed blood flow, you can see maybe a lower pulse ox, but not necessarily to the point which would cause cyanosis. Let's see, where am I going here? So, okay, so the cyanotic defects have decreased pulmonary blood flow, and those include tetralogy flow, tricuspid atresia, and hypoplastic left heart, and some mixed lesions as well. So these are less common, they're more life-threatening, and they are dependent on mixing of blood for survival initially. So after birth, usually these newborns will get a prostaglandin infusion to keep the ductus arteriosus open, so that they have a mixing of blood to increase their oxygen saturation until they can have surgery to correct. Any congenital heart defect can lead to congestive heart failure. And so a child that has a heart defect that is not being surgically corrected may be managed medically for a while, or maybe just observed. There may be no treatment. So, for example, a murmur is heard in the office, the child is sent to a cardiologist, the child has an echo, and say is diagnosed with a VSD, which is the most common congenital heart defect. Depending on the size of the VSD, that malformation, whether there's any hemodynamic significance or not, the surgeon may elect to just watch the child if the child is doing well, in which case we will watch that child. So we'll be seeing the child in primary care. The cardiologist will follow the child every few months. So the parent needs to be aware of what to look for, because at any point in time, if the defect gets larger or more significant, the child can slip into congestive heart failure. So on page 770 in your book, there's a box that reviews the signs of congestive heart failure in infants and older children. most importantly, easiest for parents is to notice during feeding, because feeding is like aerobics for babies. It's the activity that requires the most energy. So that's the activity where you will see a classic change if the child is going into CHF. It will be harder for them to feed. They will tire. They will sweat during feedings. They'll be taking less than normal, which is ultimately going to lead to slower weight gain. And so parents need to know that they need to let us know if they note that in the baby. If they pick that up, then they should come in and we should evaluate the baby. If we're evaluating a baby in the office for signs of congestive heart failure, we would see tachypnea, tachycardia. We may be able to hear RALs or abnormal lung sounds. We may be able to feel palmar pulses. The liver may be down a little bit more. There may be periorbital edema. So those would obviously indicate a need for cardiology involvement. So if a child was in congestive heart failure, we would either send the child for immediate evaluation by a cardiologist or send them to the ER so they could see a cardiologist right away. Most of the children that are going to end up going into congestive heart failure will be the ones that have excessive left to right shunting, and that's because there's an increased amount of blood flow to the lungs, which is going to lead to pulmonary edema. Some children who have congestive heart failure or who've been diagnosed with congestive heart failure will be managed medically for a period of time, put on digoxin as an inotrope and Lasix as a diuretic, and until they get big enough for surgery. A lot of times the cardiologist will want the child to be bigger and stronger and healthier before they operate. So we need to monitor for side effects from those medications and monitor the dosing, that the dose is adjusted as the child grows. There are long-term complications for children who have congenital heart defects as they transition into adolescence and adulthood. Some of the surgeries, depending on the severity of the heart defect, are only palliative or not completely corrective, because they can't be completely corrective, so they may, as they get older, end up having more problems or require additional surgeries. At Children's Hospital in Boston, a lot of times they will follow their congenital heart patients through adulthood because the original condition was congenital, so they do not necessarily send them to adult cardiologists. They'll follow them throughout their life, but those patients will not be followed by their pediatrician forever or their PD nurse practitioner forever. So they should be, they need help with transition to adult primary care. And that's pretty much all I want to say about that. So again, we just need to be aware, especially as we talk a little bit later on about sports and adolescence, to be cautious of any patient that was born with a congenital heart defect, and make sure we have clear guidelines from the cardiologist on what their activities can be in terms of competing in sports. Okay, so that sort of covers congenital heart defects and screening for congestive heart failure. And now we're going to talk a little bit about some of the common complaints that are seen in primary care that are related to the cardiovascular system. And the first one is syncope, which is not necessarily a cardiovascular problem, but we need to evaluate syncope in children for it potentially being a sign of a cardiovascular disease. Generally, it's not, but it can be. So it's something that's important not to miss. It's most important for us to be able to distinguish between a simple fainting event versus one that is a red flag for a serious cardiovascular condition. Fainting is fairly common in children, especially from like 8 to 18. There's different places will quote different numbers. 15 to 20% of children will faint. It's much more common in girls than boys. And the cause of syncope being cardiac related is rare, but important not to miss. So most cases of syncope are benign fainting, but syncope can be a sign of cardiovascular disease, and we need to be able to figure out whether it is or it isn't. And one of the part of how we do that is obtaining some clinical historical events associated with the fainting. And those appear on page 791 and 792 in your textbook. And those include obtaining what the triggering event was, because if the syncope was during exercise, that's dangerous finding. So we want to know specifically if the child was exercising during the period of syncope or not. We want to know if they've had prior episodes of syncope or fainting. This could mean that they are, quote, a fainter, or it could be a sign that they have an undiagnosed arrhythmia and that it's presented with several episodes of syncope. So we also want to find out how they have been evaluated in the past, if they've had previous episodes of syncope. Maybe they fainted 4 or 5 times, but this is the first time the mother has brought them in or sought care about it. So that's going to, play a role in what we do to work it up. Was it associated with an injury? So like a direct blow to the chest or some other type of injury? Did they have tonic-clonic movements? Did they literally pass all the way out unconscious, or were they just dizzy and felt like they were going to pass out? And a lot of times the event is not witnessed, so we never really know 100% for sure, because teenagers might think they passed out when they didn't, or might not realize that they passed out. We want to know specifically if there were any cardiac signs, such as chest pain or palpitations. That is, again, a red flag for a cardiovascular condition. So if those are present, that's going to be an emergent referral. We want to know, very important to find out if there's any family history of sudden cardiac death, because that is also considered a red flag. We have to consider the possibility of pregnancy in females who faint, because syncope is a common occurrence in pregnancy. So a pregnancy test should be obtained in females. We want to know if there was associated respiratory signs. Was there a psychological event such as fainting during blood drawing, which is sort of a vasovagal type of syncope? We want to really know as much about the history of the event as possible. And you want to do a detailed neurological and cardiovascular exam based on the history. Most of what I read aligns with obtaining a 12-lead EKG on any child that presents with syncope. I'm not sure that this is done routinely in all practices. I'd be interested to hear from you about what you're seeing in your clinical sites. If it's a classic fainting, they saw blood, they fainted, it was the first time, they're fine, they have no cardiac signs, all of their history related to cardiovascular disease in themselves or their family is negative, you may not obtain the ECG. But in the emergency room setting, all syncope patients have an ECG and all females have a pregnancy test. It's important to obtain orthostatic vital signs because a lot of times the syncope can be related to dehydration or just standing for a long period of time. Some people will get dizzy from a stressful event or anxiety. If a child gets referred for syncope, they will definitely have a more involved workup. It's also important to obtain when did they last eat. They could be have a little bit of a low blood sugar or be dehydrated. What position were they in? How long did it last? I mentioned the importance of obtaining family history, especially cardiac disease or cardiac death while a family member was quite young. Drowning, because some people will drown because they have a cardiac event in the water. Red flags are during exercise or exertion, positive family history, needing CPR obviously would be a red flag. Palpitations or chest pain presenting with the syncope, having had surgery in the past for congenital heart defect, and having a murmur on exam. So, regular old fainting, which is also known as neurocardiogenic syncope. You want to identify what the potential triggers are for that and make sure you educate the patient to avoid prolonged standing or rising quickly, to drink plenty of fluids, and avoid caffeinated drinks to increase salt. So some kids who have neurocardiogenic syncope, we actually have them have pretzels on them at all times and a water bottle, that if they're starting to feel like that they should lay down. And syncope can be a precursor to a sudden cardiac death event. So we want to make sure that we are asking these kinds of questions. In fact, these questions included in this table are recommended to be asked during all well visits, and they include asking if your child has ever fainted or passed out during or after exercise. Has your child ever had extreme shortness of breath, discomfort, or pressure in their chest during exercise? Extreme fatigue associated with exercise? Has the doctor ever ordered a test for your child's heart? Has your child ever had an unexplained seizure or exercise-induced asthma that's not controlled with medication? Asking about family members' history of sudden unexplained death, including a crash or drowning where the cardiac event could have occurred before the crash or the drowning. So these types of questions are important to assess for and to avoid missing some red flags for sudden cardiac death in children. And there's an article on sudden cardiac death listed for your reading, and we can go over that more in class. Another common cardiovascular complaint in children is chest pain, and almost never is chest pain associated with a cardiac condition in children. So children will often complain of chest pain and almost never have a cardiac etiology for that pain. Table 31.9 reviews the possible cardiac causes of chest pain, but the most common cause of chest pain in children or adolescents is musculoskeletal in origin. They have a common condition known as costochondritis, which is inflammation of the sternocosto angle, where there's sort of like an inflammation sort of right as the rib meets the sternum. And so some kids will have a psychogenic chest pain where they maybe hear family members talk about, someone that had a heart attack, and they sort of internalize that, and they start worrying that they're going to have a heart attack, and they start having what they describe as chest pain. In most cases, it's a transient, whereas kids who actually have a cardiac cause will have consistent chest pain over time. So again, when a child presents with a cardiovascular related symptom, we do want to get a very good family history, especially if sudden cardiac death or heart disease, Marfan syndrome, what their past sports activities are, any previous trauma to the area, any muscle pulls, what type of activities do they do? Are they weightlifting, somewhere that they could have put some strain on the chest area? It's critical to know if the chest pain is associated with exercise, syncope, or dyspnea. If the chest pain is associated with exercise, they need to be completely cleared before they are able to return to sports. Want to know what the quality of the chest pain is, location, does it waken patient at night, and what other symptoms. So any chest pain that's associated with syncope, exertional dyspnea, or irregularity in heart rhythm needs careful evaluation by a cardiologist. If on objective findings, in addition to having chest pain, there's an abnormal finding on cardiac exam, like a murmur, rub, or a click, or an arrhythmia, that would warrant a referral. Again, you want to assess for tenderness at the costochondral joints, reproducible pain in that manner with a normal cardiac exam points to a musculoskeletal cause. Make sure you listen to the heart rhythm, that you note a normal S1 and S2 in all 5 locations. Listen for any arrhythmias, remembering that sinus arrhythmia is normal in children. Sinus arrhythmia is when the heart rate increases with inspiration and slows down during expiration. Work them up for other causes of chest pain, such as pulmonary. Is it an asthma issue, or bronchitis, or pneumonia, or some other cause for chest pain? Depending on their presenting signs and symptoms, and the findings during exam would warrant what type of testing. So if they have pulmonary findings, you may need to obtain a chest x-ray. They may need PFTs to rule out asthma as a cause. If there's an arrhythmia disturbance, you're going to refer them, and then the cardiologist would order those tests. And if they had signs of congenital heart defect or other cardiac related conditions, they would be seen by a cardiologist. Your differential includes costochondritis, idiopathic pain, or the musculoskeletal causes. Reassure them if they have a really normal exam and they have no concerning parts of the history, no concerning findings in physical exam, but any pain that suggests a cardiac cause needs to be referred to a cardiologist. Moving on to acquired heart disease, beginning with hypertension. And again, these are conditions that never really used to be a problem in pediatrics, but now with so many other changes in lifestyle and health concerns in children, we now have hypertension in the pediatric population. So it's defined as a systolic or diastolic, or both, being greater than or equal to the 95th percentile for age, gender, and height. It's not defined until a BP has been taken on 3 separate occasions. Blood pressure that's greater than or equal to the 90th percentile is considered either high normal or prehypertensive. Blood pressure that's greater than or equal to the 95th to the 99th percentile is called stage 1. Stage 2 is when the blood pressure is greater than or equal to the 99th percentile. There's increased risk related to obesity and secondary hypertension, as opposed to primary hypertension, is usually in younger children, and it's associated with another medical condition, such as being premature and having either problems related to umbilical catheterization that perhaps left thrombi in place, or renal conditions. So there are children that do have other organ problems that can lead to secondary hypertension. So first we need to assess whether the hypertension is primary or secondary by making sure we've screened for other causes of hypertension that would lead to a secondary hypertension. And again, being a NICU graduate is a potential risk factor for secondary hypertension. Assessing for prior hospitalizations, trauma, sleep history, sleep apnea, medications, chronic illnesses, especially related to the kidney. Family history, again, of cardiovascular disorders, MI, stroke, hypertension. Clinical findings on physical exam, you want to look at the body habitus. Is the child overweight? Does the child have sign of metabolic syndrome, acanthosis nigricans, or other findings? Any dysmorphic features? Is there any edema, generalized edema associated with like a nephrotic syndrome or some other renal problem? Any lesions that could be indicative of neurofibromatosis or lupus or tuberous sclerosis. You want to assess extremity pulses. You want to do a fundoscopic exam if possible, looking at the fundus, looking at the optic disc. And let's see. Diagnostic studies are going to depend on the underlying cause. If the child is less than 10, then they probably need to be seen by a specialist, probably a nephrologist, because in most cases the problem is renal related. And if not, then you want to get lipid studies. You want to get a lipid panel. So in hypertension, the management of hypertension, we screen all children for hypertension starting at age 3 at all well visits. If they have prehypertension, we want to do 2 follow-up blood pressures. If they are hypertensive and overweight, we want to try to treat the obesity with lifestyle changes. Some primary care providers are comfortable managing hypertension alone with antihypertensives. But if you have never done that, my recommendation is to refer to cardiology to at least have an evaluation and then get an opinion from them on which medication would be appropriate if it's necessary. Once you've been practicing for a while, if you end up having a lot of experience managing hypertension in your population, you may feel comfortable once you have determined that it's primary hypertension, managing it yourself with antihypertensives. But in most cases, because this is a relatively newer phenomenon in pediatrics, many of us have not had enough experience to manage these children independently, at least initially. So a referral to a cardiologist initially, and then perhaps being followed after that in primary care is most appropriate. So this is just a couple of tables demonstrating what is actually meant by the different stages of hypertension in terms of what the blood pressure actually is. And this is a very basic screening list of blood pressure measurements that would warrant at least follow-up measures. So as you can see, in children greater than or equal to 13, any blood pressure greater than 120/80 would warrant at least subsequent measures of blood pressure. You would not just accept that blood pressure without doing further evaluation. And this slide is a I'm blanking on that word, but you know what I mean, to sort of algorithm of how to manage blood pressure in the primary care setting. And we posted several articles on D2L about managing hypertension in the primary care setting, reducing cardiovascular risk factors in children, and advising children on participation in sports with hypertension. So I would recommend reviewing those as well, and at least downloading those as resources for you to use in clinical and then after you finish and you graduate. Okay, so I took out heart conduction disturbances, but we are going to talk about acute rheumatic fever briefly, just to review, because I know you had this last semester. And this is an autoimmune process. Generally, that is a complication of a group A strep pharyngeal infection. And this process tends to involve the joints, the heart, the central nervous system, and the subcutaneous tissue. And the syndrome can recur with subsequent group A strep infections. And this is why we put children who have had acute rheumatic fever on prophylactic penicillin to prevent further episodes of group A strep. The Jones criteria is used to make the diagnosis, and it is helpful to know that there was an evidence of a group A strep infection by obtaining an ASO titer. The Jones criteria include major manifestations and minor manifestations, and the diagnosis is made with 2 major or 1 major and 2 minor. And you can see that these are the major manifestations here. These are the minor manifestations. Diagnostic studies will include measuring acute phase reactants, looking at a CBC for leukocytosis, and measuring an EKG where there would be a prolonged PR interval. The differential includes other connective tissue diseases and autoimmune diseases. And the management includes antibiotic therapy to prevent ARF when a group A strep culture is positive, anti-inflammatory therapy for the acute rheumatic fever, usually aspirin and then tapered after 2 weeks, sometimes steroids, referral to a cardiologist, and again, prophylactic penicillin. Okay, moving on to pediatric vasculitis. We're going to talk briefly about Henoch-Schönlein purpura, which is the most common vasculitis of children. Again, this often is preceded by a group A strep infection or another URI. The presenting complaint is usually abdominal pain with a palpable petechial purpural rash on the lower extremities. And there can be renal involvement. The cutaneous palpable purpural are the hallmarks of the disease, and I have seen this, and it's very profound. There are like these purplish lumps all over the thighs. If a child presents with that, you want to obtain a urinalysis and renal studies. HSP can lead to nephritis or nephrotic syndrome, and so these children will need to be followed. Their renal values will have to be followed. It's more frequent in winter. It's males greater than females. The 2 times I've seen this, it was in males. They can also have arthritis or arthralgia. The rash, again, is generally on the lower extremities. They may have some arthritis in their knees and ankles. They kind of have diffuse abdominal pain. They can have edema of the scrotum and their eyes. You can have hypertension, so make sure you assess for that. They should be followed closely until the vasculitis resolves. You'll want to obtain a UA and a BUN and monitor those until normal. Depending on how involved, if their renal studies are abnormal, you want to involve a nephrologist. If it's a severe case with GI complications or pulmonary or renal complications, they may need to be hospitalized. Outpatient, if it's a mild case, you can manage it with NSAIDs. And there can be complications from this. Again, close monitoring to ensure that complications do not present, or that early referral can take place for complications. And I think we're just going to end with Kawasaki's. We're almost at an hour. I'm sorry it took this long, but Kawasaki disease is a syndrome. It's a mucocutaneous lymph node syndrome. It's an acute generalized systemic medium vessel vasculitis. The cause is unknown. An infectious agent is believed to be involved as triggering an immune response. There's low person-to-person spread. There's a classification syndrome system, which includes persistent fever for at least 5 days, plus 4 of the following: bilateral conjunctival injection without discharge, so just injected conjunctiva. Changes in the lips or oral cavity, including red, chapped or peeling lips, red in the buccal cavity, cervical lymphadenopathy, a polymorphous exanthem, and changes in the peripheral extremities, either swelling or peeling of the hands and feet and perineal area. Some may have an atypical presentation, an incomplete KD, but they will have coronary anomalies on echocardiogram. One of the most significant complications of Kawasaki disease is coronary artery aneurysms. They can become very irritable, have aseptic meningitis, and having mild eye findings, including uveitis or iridocyclitis. There's usually a 2-stage process. So the acute phase lasts from 0 to 14 days, where they have the abrupt onset of high fever, which tends to not be responsive to antipyretics or antibiotics. They're quite irritable. They have the bilateral conjunctival injection, erythema, fissuring of the lips, a strawberry tongue, the rash, the adenopathy, and edema of extremities. Then they move into their subacute phase for 2 to 4 weeks with its resolution of fever until all other symptoms are resolved. The irritability may persist. They may have desquamation or peeling of the fingers and toes, arthralgia, arthritis, orchitis. And then stage 3 is the convalescent phase, where all clinical signs resolve, but laboratory values have not returned to normal. They may have nail changes, and if they do have coronary complications, they can persist into adulthood. Kawasaki is a diagnosis of exclusion. You want to exclude other causes of fever prior to labeling 5 days of fever as Kawasaki. Thrombocytosis is also prominent in Kawasaki. Their platelets can go up to over 1 million in the subacute phase, which can lead to thrombosis, coronary artery thrombosis, which is why they are treated with aspirin, usually, for their antiplatelet activity. Again, the ESR will be quite elevated, platelets will be elevated, the CRP will be elevated, and there'll be a high white count. You want to make sure you obtain cultures to rule out other sources of fever. If you have made the diagnosis of Kawasaki, these children should see a cardiologist, and because they will order the cardiology diagnostic tests. The differential includes other causes of fever, viral bacterial infections, and other rare conditions. You should seek a consultation if you're concerned that your patient has this disease for help in diagnosis. So to prevent aneurysms and coronary thrombosis, they will be put on usually high-dose aspirin and IVIG, which also helps in reducing coronary artery abnormalities. Sometimes they will use steroids. Again, these children will be referred to cardiology. Follow-up will depend on whether the coronary complications persist or resolve. And that's the end of your cardiovascular PowerPoint presentation. There are other conditions that we will go over in class, and if you have any questions, let us know. Have a good day.